Second speaker of today is Dr. Nanako IWAMI from Kamiya Ladies Clinic, Japan. The title of her talk is Efficacy of EMMA with Recurrent Implantation Failure and Recurrent Pregnancy Loss, Multi-Center Study in Japan. Dr. Nanako IWAMI is the physician in Kamiya Ladies Clinic from 2014. She received MD degree from Sapporo Medical University in 2005. And now she not only is the doctor in Kamiya Ladies Clinic, she's also the National Board of Medicine Registration and also a board member of Japanese Society of Obstetrics and Gynecology. And she's also a board member of Japanese Society of Reproductive Medicine. Dr. Iwami, would you please turn on your video and microphone, and would you also please share your slide on the screen?
Okay. Thank you for the wonderful introduction, and thank you for giving me the opportunity to present our work here. I have no financial relationships with commercial interests to disclose. Introduction. The endometrium cavity has traditionally been considered a sterile cavity because the endometrium contains 4 orders of magnitude fewer bacteria than the vagina does. Recently, using NGS allowed for the detection of both culturable and non-culturable bacteria. And thanks to this technology, analyzing the bacterial 16S ribosomal RNA with NGS can determine the composition of the endometrium microbiome. Endometrial bacteria in patients undergoing IVF are identified to be related to some pathogenic microorganisms which decrease implantation rates, such as Enterobacteriaceae family and Staphylococcus spp, Escherichia coli, and gram-negative bacteria. Other studies also indicated that the species of Lactobacillus is the major flora in endometrium. Displacement of Lactobacillus species by other bacteria caused a decrease of implantation and pregnancy rate in these patients. In this study, we expected to observe a relationship between the improvement of endometrial microbiome balance and the increase of reproductive success in patients undergoing artificial reproductive technology. We use diagnostic tool endometrial microbiome metagenomic analysis EMMA by analyzing bacterial 16S ribosomal RNA by NGS technology to determine the composition of the endometrial microbiome. EMMA is used to determine the optimal intrauterine bacterial environment for embryo implantation. EMMA indicates the endometrial microbiome balance, providing information on the proportions of all endometrial bacteria, including those linked to higher pregnancy rates. EMMA can determine the percentage of lactobacillus present in the endometrium, and it will determine whether the uterine microbial environment is optimal or not for embryo implantation. EMMA also includes ARES, which detects pathogenic bacteria that can cause chronic endometritis. ARES also uses NGS technology to provide microbiome information in endometrium tissue by analyzing the abundance of specific bacteria causing chronic endometritis. Specific bacteria include Escherichia, Klebsiella, Staphylococcus, Streptococcus, Enterococcus, Neisseria, Chlamydia, Ureaplasma, Mycoplasma. Methods. This study was a prospective multi-center cohort study of 527 patients under 42 years old at 14 IVF treatment facilities in Japan from June 2019 to August 2021. The 14 facilities are listed here, and all were conducted at GISART registered medical facilities. All patient centers are responsible for assigning inpatient, recruitments, and sample tissue obtained. Sample tissues will be shipped to Igenomix for EMMA and ARES tests, followed by result notifications. This research project will respect the essential principles established in the Declaration of Helsinki, and this clinical research was also approved by the GISR-ART's Ethics Committee. These lists were inclusion criteria. The patients who fall under these lists, at least one of the following cases will be strongly recommended this project. Infertility for 3 years or more, recurrent implantation failure, recurrent miscarriage, biochemical pregnancy, patients with suspected CE with hysteroscope diagnosis, CD138 positive cases with plasma cells confirmed by histological examination, bacterial vaginosis causes confirmed by bacterial culture. And exclusion criteria has shown this slide. Particular attention was paid to exclusion criteria, cases that had been using antibiotics for less than 3 months were excluded. In Japan, preventive administration of antimicrobials is very commonly used, and some facilities routinely administer antimicrobials for 3 to 7 days for examinations and minor surgery. Since the endometrium microbiota is a low biomass, we have made it a rule for facilities participating in the study to refrain from using antimicrobial agents prior to testing. A flowchart of the study is shown here. Participant centers should treat the patients following the description specified in EMMA or ARIS reports. EMMA reports normal results, which indicates the patients with endometrial microbiome dominated by genes lactobacillus will continue their treatment according to the standard protocol of the clinic. The patients have EMMA reports, mild dysbiosis, and ultra-low biomass result has received probiotic treatment to their vagina. The patients with abnormal results, antibiotics, probiotic treatment, reanalysis, and embryo transfer after reanalysis. Data of implantation rates, ongoing pregnancy rates, and live birth rates should be collected by participant centers after embryo transfer for analysis. We examined the prognosis of 2 additional embryo transfers after the EMMA test in patients who underwent the test. We performed these statistical analysis using our software. For between group comparisons, items showing a normal distribution were tested for ANOVA, otherwise Carl-Wallis and Fisher tests were used. For cumulative evaluation of ongoing pregnancies, only the initial results were included, and a multivariate analysis using a generalized linear model was performed with the endpoint of the ongoing pregnancy. For the time to event analysis, we use Kaplan-Meier survival analysis to compare time to ongoing pregnancy. I will explain the result of the study. Of the study participants, 527 cases were available for analysis. The average age was 37.7, and the median duration of infertility was 33 months. Here is breakdown of the EMMA results. Novel group, which has a very good endometrial status with lactobacillus predominance, according for 229 patients, 43% of the cases. And the mild and ultra-low groups, which probiotic treatment was recommended, 188 patients accounted for 22%, 14% respectively. The patients with abnormal were 110 patients, 21% of all patients. Of these, only 5% of patients diagnosed as ARIS positive. In the present study, the results were divided into 3 groups: normal, abnormal, and mild plus ultra-low. Mild with high lactobacillus counts, abnormal with dysbiosis, and mild plus ultra-low with low absolute bacteria counts to evaluate the pregnancy outcomes. First of all, we evaluated whether there were differences in patients' background, age, duration of infertility, number of previous embryo transfer were compared with no significant difference in background. These are predominant bacteria detected in more than 10% of patients with abnormal result, other than lactobacillus. The results are shown in a box and whisper plot of median and standard deviation of percentage of bacteria detected. Most abundant bacteria detected in the abnormal group was Gardnerella, which was detected in 62.7% of patients. The next common bacteria detected was Atopobium, detected in 42.7% of patients. The third most frequency detected bacteria was Bifidobacterium, detected in 31.8% of patients. Streptococcus were detected in high number among the RS positive patients. The results show a summary of the extent to how much lactobacillus was detected in the abnormal groups. Cases in which more than 80% of endometrial microbiota has been replaced by bacteria other than Lactobacillus spp. So treatments were based on the following post-intervention. In the group with abnormal results, antimicrobial therapy based on bacteria detected in more than 10% of dysbiotic causative bacteria, and then probiotic therapy. In the group with mild dysbiosis, ultra-low biomass, probiotic treatment was recommended. They used tablet included lactobacillus for vagina. In the group with normal results, they do not need additional treatment. Here is the breakdown of antimicrobials as recommended treatment based on the results. From those results, combination treatment with amoxicillin and clavulanic acid was recommended in 46.4% of cases, and metronidazole was recommended in 41%. 70% of patients improved after the first recommended treatment, but 30% of patients did not improve and were treated with additional antimicrobial agents different from those used in the initial treatment. Clindamycin was most frequently recommended antibiotic for second-line treatment. Doxycycline, a broad-spectrum antibiotic, is often used to treat chronic endometritis. However, there was no case that the suggested treatment was broad-spectrum antibiotic during this trial. The results of multivariate analysis with ongoing pregnancy as the endpoint are shown here. There was no significant difference in the rate of ongoing pregnancy in either the abnormal group or the mild plus ultra-low group compared to the normal group when the intervention was performed after the endometrium analysis. The only factor that significantly differentially affected ongoing pregnancy was maternal age. And we also checked other findings suggestive of chronic endometritis and its impact on the rate of ongoing pregnancy by multivariate analysis. The effect on ongoing pregnancy of hysteroscopic findings, such as micropolyps, edema, hyperemia, which is used to diagnose chronic endometritis, and the presence of CD138 positive cells by immunohistochemistry, which was performed prior to the current examination. Multivariate analysis shows that none of the items were significantly associated with ongoing pregnancy rates. Since age is a factor that influences continued pregnancy, EMMA results were also analyzed for differences by age. The results were compared by Fisher's exactly probability test for each age category, and p-value were corrected by using the Bonferroni method. And no significant differences were found between the age categories. Although the results of multivariate analysis showed no significant difference between abnormal and normal results in terms of ongoing pregnancy, we tried to verify the result by including the time axis as well. Kaplan-Meier spiral curves were used to analyze the effect of post-EMMA intervention on the outcome of ongoing pregnancies, including the time case scale involved. The results showed a significant improvement in pregnancy outcome is abnormal group compared to normal group and mild ultra-low group at observation time 6 and 12 months. The abnormal microbiota group was significantly more likely than the other groups to have an ongoing pregnancy earlier than the other groups following post-test interventions. And when evaluated by age group, the following results were obtained. For patients 30 years old or younger, the following post-intervention result in a pregnancy outcome similar to that of the lactobacillus-dominated monovalent group. The post-intervention effect was greater for those 36 years old or older than for younger women, with a smaller p-value and better pregnancy outcomes in the dysbiotic group. This suggests that the intervention may result in earlier pregnancies. And assessment of ongoing pregnancy with and without intervention. The red line is the normal group in which lactobacillus was presented in more than 19% of the initial test result. And transplantation was continued without any specific additional treatment after the test. The blue line is the group with less than 90% lactobacillus in the initial test result and includes abnormal, mild, and ultra-low. This group of patients received following post-test intervention, such as microbials and probiotic therapy to improve the lactobacillus presence. As for the group of patients who needed intervention, more patients became pregnant earlier with post-intervention embryo transfer. The result here showed a p-value of 0.033, indicating a significant difference between the two groups. From the perspective of concerns about bacterial resistance, we should avoid recommending the administration of broad-spectrum antimicrobials for 2 weeks with the causative organisms unknown. And we believe that the administration of minimal antimicrobials only when necessary, according to the bacterial status in the uterus, will also help reduce patient burden. So the overall result of EMMA was similar to those previously reported, with 21% of patients requiring antimicrobial therapy. The group with abnormal EMMA result had early pregnancies, which suggests that RIF and RPL were caused by abnormalities in the uterine microflora. In these cases, it is suggested that treatment focused on this point may lead to early continuation of pregnancy. Limitation. Since study was not necessarily limited to improved embryo transfers after testing, and aging biomes cannot be excluded. Since this study was conducted with all patients receiving EMMA, The effectiveness of the test needed to be further validated by comparison patients without EMMA testing. Conclusion. Analysis of the intrauterine microbiota 16S ribosomal RNA gene sequencing as a part of the search of cause of RIF and RPL provided detailed information on the intrauterine condition and allowed intervention with minimal antimicrobial therapy according to the causative organism, only in patients who need it. Furthermore, the results suggest that following post-test intervention may be effective for achieving early and ongoing pregnancy. We would like to thank all those who have helped us in this research. Thank you very much to Igenomix and Vitrolife for giving me the opportunity to make this presentation. Thank you for your attention.
Thank you very much, Dr. Iwami, for a wonderful presentation. There's a little time left, but I would like to ask a few questions from the audience. So in your clinical data, you put mild and ultra low patient in same group. Does that mean the pregnancy rate and the treatment strategy are the same for those mild and ultra low groups?
Yes, mild and ultra low contains a low number of bacteria, but we already checked the pregnancy outcome, mild or ultra low. We already performed multivariate analysis. Mild or ultra low were compared separately for both implantation and continued pregnancy rates, but there was no significant difference compared to normal.
Thank you. Another question is, one of your slides shows the influence of microbiome to immune environment. And Dr. Nakagawa also shows that potential relationship of immune environment and endometrial receptivity or window of implantation. Is it possible that microbiome can influence window of implantation from your experience?
I think we have to more discussion or more study has needed. However, Moreno et al. 2016 and 2022 reports examine the impact of EMMA on pregnancy after adjusting and combining ERA and performed personalized ET. Even after adjusting ERA, pregnancy with abnormalities in EMMA prognosis is poor. So the impact on ERA is considered different.
Thank you. And another one, just one more. Is there any particular guidelines of antibiotics or probiotics prescription after EMMA test? Is there any guideline in your clinic or a guideline in your country, or is there any fixed policy for what antibiotics or probiotics should be prescribed?
We usually use antibiotics selected based on EMMA result. Almost EMMA result antibiotics we can use, and provide treatment. In Japan, we can get the INVAG and lactoflora. Both we can use. So usually patients INVAG or lactoflora we can choose. Okay.
Thank you very much. Now there is a time to close down the session. Thank you very much for all the patients dialing in and sending us a question.